and recruitment updates, a little bit of general study updates, a reminder about remote consenting and that process. We're going to introduce a new resource to all of you that we're calling Resource Parents that can help you all with your recruitment activities, and then a refresher on some of the biospecimen collection techniques. Next slide. And so we are now up to 41 of our 42 sites activated. The last remaining site, Vanderbilt, is super close. I think the ink is wet on the contracts, and then we need to do some training. So hopefully we'll get them up and running later this month. As of last week, we had 176 patients randomized. 32 sites have recruited at least one patient, and Emory randomized its first patient last week. And I believe that Nicholas Children's in Miami is in the process of randomizing their first patient, or maybe did so over the last day or so. So it's great to see more sites engaged and in the game. As for the last couple of months, Cincinnati, Stanford, and Children's Hospital of the King's Daughter remain our lead sites. Next slide. And again, this is our typical recruitment graph showing the number of patients recruited by site. I'll let you look at that and spend a minute to identify your site and think about what it will take to get your site on the graph if you're not yet on the graph, or further to the left if you're towards the right, or even if you're Cincinnati, how to get even higher up on the graph. That would be wonderful. Next slide. Some general study updates. I think many of you know that Michelle Jeffcott-Pera, our Cincinnati Children's-based site manager, left at the end of July. She was a wonderful coordinator. I know many of you interacted with her on a regular basis. She'll be starting a new job in the public school system in the district where she and her kids live. In the meantime, Ann Firestein at UNC will be covering until a new Cincinnati-based project lead is hired, and contact information is on here. She's been with us at least 6 months, but it seems like longer than that, and is fully prepared to coach and answer all of your questions. And Josh remains available for monitoring, data querying, and any other questions that you guys have. So he will continue to be reaching out to you and part of our central study team. Next slide. Just a general study update. Many of you know that the Improve Care Now Fall Community Conference is next month. The official dates are the 13th through 15th. Registration is open until August 31st. So plan your schedule and make your reservations soon. The hotel discount is only available until August 22nd, or until those rooms sell out. I just booked my reservations this week, and the group rate is about $150, which is fantastic. I compared that to the discounted AAA rate, which was $300 a night. So you definitely want to be in the group of people that get a reservation in the Improve Care Now block of rooms, or you'll be paying a heck of a lot more. Combine is having a investigator coordinator team staff meeting immediately following the community conference on Saturday. So the community conference is scheduled to end Saturday at noon. There will be boxed lunches available, and we will run our Combine meeting from 12:30 until 2 p.m. We will end sharply at 2 p.m. So not 2:30 as shown on this slide. So for those of you who are trying to book travel plans accordingly, we will be done promptly at 2, so you can make a flight, anytime after, say, 3:15, 3:30, depending on how early you like to get to the airport. I will pause here and see if there's any questions that anyone has about the community conference or about our combined meeting that we are piggybacking onto the community conference. So if you do have a question, raise your hand. Otherwise, I'll pause for about 10 more seconds before moving on. If nobody has raised their hand, then Josh, you can move on to the next slide. We are having a database lock happening soon so that we can prepare our reports for the fall DSMB, or Data Safety and Monitoring Board meeting. So for all of your patients that have been randomized, and for all of your follow-up visits that have happened, say, through the end of the week this week, please try to get all of their data entered and cleaned up by August 15th. It would be a good time to go through your exception reports and data queries and other reports that Anne demonstrated last month on our investigator coordinator calls, and do a little bit of your own housekeeping as well, so that when we present to the DSMB, we are presenting complete and up-to-date data. On some of your queries, if something is permanently missing and there's just no way in the world that you can recover it, you can indicate that it is permanently missing, which should close out that query, and when applicable, add that deviation to your site's deviation log. Next slide. I should, actually going back to the prior slide for a sec, I should mention that the database lock is for cutting the data and sending it to our statisticians to analyze. Nothing will actually be locked on your data entry interface. There won't be any downtime or anything like that. So it will remain business as usual for you. This is just a sort of push to get all of the queries answered and visits entered by August 15th. All right, next slide. And an introduction to Jen Clegg, who many of you have heard from. Jen is our PRO expert and manager from CHOP, the Children's Hospital of Philadelphia. They are running our PRO core and developed the PRO surveys that we give to patients at enrollment and at 5 visits over the course of the study. Jen is currently trying to track down 45 outstanding PRO forms that coordinators across all of our sites have indicated were collected in the system, but she doesn't yet have that survey, so she will be, if she has not already reached out to you, please respond to her queries briefly, quickly, and send over those PRO surveys. They can be emailed to the address shown here, promise@email.chop.edu. And just as a reminder, for the PRO surveys or any other document, in order to avoid any version control issues, the latest and greatest of every document is always posted on the SharePoint site. So that's where coordinators can, or PIs can go, access the most current version of any of the CRFs, of the protocol, of the manual of operations. If you need unblinding, any of that sort of stuff, go to SharePoint and pull it down from there, and you'll know that you are working with the most recent version of anything. Next slide. In terms of remote consenting, just to remind all of you that we do have the option to obtain consent by telephone, email, MyChart, whatever means you would like to communicate with families. You will complete the consent, assent, knowledge confirmation surveys, all of that by fax or email or U.S. Postal Service. You'll complete a informed consent progress note and indicate how you consented that patient in that informed consent note. You can refer to page 27 of the Manual of Procedures for doing so. And whether you're remote consenting or in-person consenting, make sure that all of those documents together get uploaded into the consent management system. So basically scan together the parental consent, the child assent, the knowledge confirmation survey, the whole deal, and upload that into the consent management system as one big PDF. I've had a couple of sites ask me for a extension to our sort of 6-week time frame where we want to enroll patients after starting the anti-TNF. And while we are desperate for participants, and I'm generally willing to grant exceptions for cases that are a little bit longer than our 6-week window, I do encourage you to do remote consenting so that you can get them in and randomized before that 6-week timeline has expired. You don't need to wait for them to come in for a infusion that happens to be scheduled on day 43. You can get them remote consented on day 40 or 41 and randomized so that they are already randomized by the time they come into their day 42 or 43 or 44 infusion, and you won't need a exception. Let me stop there, see if there's any questions about remote consenting. If you have any questions, raise your hand. Otherwise, we will continue on. All right, Josh, you want to move on to the next slide? And I think Anne is going to pick up from here, if my memory is correct. Yes,
yes.
Go ahead, Anne.
Yes. Good morning, everyone. We are really excited to be able to roll out our resource parents. These are a group of parents that have gone through our training, and they have been part of the combined study for at least 3 months. They have volunteered to help educate parents wanting to learn more about the study before they sign up. So this should probably all be done prior to consenting. If you have any parents that have questions, want to talk to another family that has gone through that situation, these are the parents that you're going to make available. So they're available to answer any questions from any parents. They can tell their own personal story and their perspective, some of the questions that they thought about, what should they ask their doctors, what they did. And so these are people that have walked this path before. They've been trained to take care of private health information and to be all HIPAA compliant, and also to pass along anytime there is a medical question, to refer those back to the doctors and the clinicians to answer those questions. The next slide, please. So we currently have 5 families that are trained as resource parents. So please let any of your prospective parents know that these people are available. If they would like to talk to someone, one of these resource parents, then please email me. I'll provide you with the name and contact information of one of the resource parents, and then you will pass along that information to your prospective parent. And it will be up to the potential study participants to reach out and contact the resource parents. The resource parents won't be calling your parents. You'll provide that phone number or email to them to reach out. Any questions at all about the resource parents? Okay, let's go on to the biosamples then.
Looks like
We got a question?
I was just going to add Lisa Pitch is on the phone if you would like her to discuss the resource parents at all.
I would love that. Lisa, do you want to say a few words about that?
Let me unmute her really quick.
So Lisa is one of our parents that has been involved in training these new resource parents, and she has just been a wealth of knowledge and a wonderful resource herself.
Lisa, you're unmuted if you would like to say anything.
Mike, do you want to add a few words about this?
Sure. Yeah, Lisa, I guess we must be having some technical difficulties, but if you are able to chime in, please do so. I will say that this is or was largely inspired by the experience that many of our centers have had when a patient is contemplating surgery. We've often linked them up with another family who has had that or a similar operation in the past. When we are starting an anti-TNF, we will often link the family up with a family who's been down that route before. From the clinical side of things, we've heard that that is very useful and very helpful, and so we've, for Combine, extended that to the research side of things as well. We've done a little bit of looking and know of no other study in any disease type where current participants serve as a resource to potential future participants. So this really is groundbreaking. We don't know if it's going to be helpful or not, but we certainly encourage you all to try this out at your sites and report back on if and how this was helpful to your families that were considering participation. And you know, I'm dying to sort of hear how this experiment works. I know it took a ton of time and effort to develop the training programs, to work with the IRB, to make sure that this was all squared away and above board and legitimate. So I hope that there is utility in this for families that are considering participation. All right, we'll assume Lisa's phone doesn't work, and Anne, why don't you move on?
Yep. Let's talk about biosamples. So these are the samples that are collected during visit 3 and visit 9. If by chance they are missed during those visits, then please capture them during visits 4 and 10. So if collecting your samples Monday through Thursday, please ship these tubes directly to the UNC Biobank. Do not process any of the samples. So if it's a Monday through Thursday, collect the tubes of blood, simply invert them, I think it's 5 times up and down, let them sit for 30 minutes, and then package them up and just send them on their way. So nothing else needs to be done with those. If your samples are collected on a Friday, then you will have to pre-process these samples. So if you don't have the equipment or the ability to process according to the lab manual, please do not collect your samples on Fridays. Next slide. So if you are processing the samples on Friday, please label rubber band the primary collection tubes with the aliquot tubes. So what we've been having happen often is that just the aliquot tubes are sent in, and there's no way to really determine if the serum was coming from the red top tube or the gold top tube. So this way, if you just rubber band them all together, then there will be no question as to where this came from. Another thing that's been happening too is just to please make sure that the aliquot tubes that you're using are screw tops and not pop tops. We've had some issues where some pop top aliquots have been sent in, and of course it's so easy to just pop up and we are losing those samples. So these, also a reminder that these aliquot tubes are usually standard issue in your own lab. They are not included in the kits that we send to you, but most labs will have these available for you, so it's whatever your site is using. But please make sure that they're screw tops. Another issue that we're having, is you're going to see this on the next slide, is to remember to put the frozen gel pack inside the Insul tote with the tubes when you're shipping. So there have been a couple of cases where the gel pack is put on the outside within the box, but only the tubes are inside that insulated package. So you're not able to actually freeze those or keep those samples cold. So please remember to put that gel pack inside this insulated bag. The Combined Site Lab Manual 5.0 is the latest version of the lab manual. You're going to find that up on the SharePoint site with all other current lab manuals, and so make sure that you grab that. And then, as always, contact Nancy if you are ever missing any kit supplies, you have any questions, you need some new supplies, or you have expired tubes. Nancy is your contact person. Please reach out to her whenever you need to. And that is, I think, all we have for today. Just here's our typical slide here of who to contact if you ever have any questions. And we are always here for you. We appreciate everything that you're doing for the study. And just don't hesitate to ask us any questions. Mike, you want to add some goodbyes?
I cannot do it any better than you did, Anne. So we can hang on for a bit and see if anyone raises their hand with questions, and otherwise conclude our monthly call for August. All right. Well, thanks everyone for calling in, and we'll talk. Oh, go ahead, Josh. Yep, let's do it.
All right. Yeah. Katie Lake.
Sorry. I just had one quick question. I know that you talked about the 6 weeks from the Remicade infusion. What's the current? My problem is more with the randomization within 30 days of a clinic visit, because a lot of times they go in for a clinic visit and it takes a couple weeks for the Remicade to get approved or things along those lines. What are they, I mean, if the doctor can't come to an infusion, so one option is, can the doctor come in and do just like a physical exam at an infusion, or are there other options?
Absolutely.
Or, okay, so but if they can't make it, like if the infusion's on a Saturday or something like that, are there any other ways around that 30-day from a physical exam? I didn't know if you'd dealt with this. You know, I know this has been an issue for our site before, and it's just continuing to be one. So I don't want to preclude people, but
it seems like it is more of an issue for your site than others. I think because of your scheduling of infusions in different locations in different days, where it's hard for providers to reach patients. But you know, if the decision to start the biologic happens at a endoscopy rather than a clinic visit or something like that, you know, a quick history and physical from that day of endoscopy could count. Okay. We just like to have, you know, essentially it's really nice to have a baseline status of how the patient is doing before they randomize into the study. And if there is no history or physical within 30 days of randomization, it's hard to have any baseline data to evaluate response from.
Okay. All right. So if they can do, you know, quick physical at the infusion, great. But if not, I guess we'll just kind of reach out on it if there's a case or something along those lines. Yeah,
and if it's 31 days, it's probably not a biggie. But again, it's just nice to have some degree of baseline history and physical data, you know, as close to as possible the date of randomization.
Okay. Thank you.
Thanks. Yeah, always a good question, Katie.
I'm not seeing.
All right, Josh, if we don't have any other questions, I think we can wrap.
Okay, thank you, everyone.
All right, bye, guys.
Thank you.